Welcome back, everyone. We're, of course, here at our usual time this week. Dr. Kelly Victory, on her usual day, will join me again. We are taking questions off Twitter Spaces. I'll get in there in just a second to make sure we have access. Don't worry. Kayla will be out there. Just I've got to drop in. And the conceit of today's show was all things medical other than COVID, though I'm afraid Kelly and I have a few things hanging over from yesterday we kind of want to get into before we launch into other topics, but Susan's laughing. I also noticed that Susan was in on the Rumble rants talking about whether or not RFK Jr. should have Secret Service coverage from the federal government. Hysterical. We can talk about things like that if you wish. Those of you who are on Rumble may have just seen an interview with RFK Jr. I was with him over the weekend at a very interesting presentation, a 5-hour afternoon of multiple presenters in San Jose, and I thought it was a very productive afternoon and evening. Again, back with your calls. We'll be on Twitter Spaces taking those calls. Raise your hand there. I'll call you up after this.
Our laws as it pertains to substances are draconian and bizarre. The psychopaths start this way. He was an alcoholic because of social media and pornography, PTSD, love addiction, fentanyl and heroin. Ridiculous. I'm a doctor, for sake. Where the hell do you think I learned that? I'm just saying, you go to treatment before you kill people. I am a clinician. I observe things about these chemicals. Let's just deal with what's real. We used to get these calls on Loveline all the time. Educate adolescents and to prevent and to treat. If you have trouble you can't stop and you want to help stop it, I can help. I got a lot to say. I got a lot more to say.
I think everyone knows the next medical crisis could be just around the corner, whether it comes in the form of another pandemic or something much more routine like a tick bite. You and your family need to be prepared. That's where the Wellness Company comes in. You know the Wellness Company. We have their physicians on like Dr. McCullough frequently. The Wellness Company and their doctors are medical professionals you can trust. And their new medical emergency kits are the gold standard when it comes to keeping you safe and healthy.
It's a safety net. It's an insurance policy
absolutely.
That you hope you're not going to
100%.
need, but if you need it, you sure as heck are going to wish you had it if you need it.
Be ready for anything. This medical emergency kit contains an assortment of life-saving medications, including ivermectin, Z-Pak. The medical emergency kit provides a guidebook to aid in the safe use of all these life-saving medications. From anthrax to tick bites to COVID-19, the Wellness Company's medical emergency kit is exactly what you need to have on hand to be prepared. Rest assured, knowing that you have emergency antibiotics, antivirals, and antiparasitics on hand to help you and your family stay safe from whatever life throws at you next. Go to drdrew.com/TWC. That is DRDREW.com/TWC to get 10% off today. Just click on that link. And tomorrow we will have some news about my participation with TWC. I think they're doing a great job of trying to improve access for people that are not so trusting in the medical system anymore. We're trying to rebuild that trust and trying to put some of the locus of control for healthcare back in the hands of patients. So that is my goal in getting involved with TWC. So keep a lookout for that. I'm pleased with their responsiveness, how they're problem solving, and I think we can do some good there. Dr. Kelly Victory joins me, of course. Kelly is an ER doc. She has public health training. I don't have to, we will undoubtedly, when we come out of commercials next time, there'll be another review of who Kelly Victory is. That's all tapped into our automated system. So she'll be there. She'll be promoted again when we take a little break. But I don't want to go to calls just yet because there's a bunch of stuff I want to talk to you about. Let me just talk to you about one thing in particular to start with, because you and I both have kind of a hangover from yesterday. Some of the calls we took, some of the conflicts we were getting into and stuff.
Right.
And I woke up in the middle of the night and I was awake for an hour thinking to myself, now, wait a minute. How can I question the point of view, the position of the American College of Obstetrics and Gynecology and essentially the Royal Society of Obstetrics and Gynecology and every other society, professional society, particularly that I've been looking at the pregnancy data lately and trying to understand it, because so much of it is earlier, so much of the great benefit was earlier. I'm trying to understand why the push now. And I just thought to myself, who am I to run afoul of these great and storied professional organizations? I will let you answer that, and then I want to tell you what my next thought was after about 45 minutes. I'll let you answer that first.
Right. Well, let me start with this. I think, unfortunately, I think that people underestimate the power of financial incentive. These all, there's no question that the different colleges, just like the medical journals, Drew, are highly supported by the pharmaceutical companies. If you look, for example, at what happened with the average internist, family practice physician in the United States, makes $200,000 a year. The average practitioner has 1,500 patients in his or her practice. Those are just the numbers. The insurance companies incentivized doctors financially to get their patients, for example, vaccinated for COVID. This has never happened before. They didn't do it for influenza. They don't do it for meningitis or for pneumonia, but they did for COVID. And they incentivized people, these doctors, $300 per patient if you had 70% or more of your practice vaccinated. So let me just do the math for you. That means that your average doctor who was making $200,000 a year, if he or she got 70% of their practice vaccinated, 70% of their 1,500 patients, they would have made an additional $550,000. They would have gone from $200,000 to $750,000 last year. Okay? If you don't think that that's an incentive, now, I'm not saying that a doctor says, oh, I don't believe in this, but since I'm getting paid, I'll give it. But when it's really subliminal. It's really when you're going, oh my gosh, I'm motivated to get my patients vaccinated. And you see past, maybe you don't delve into the studies as much as you can. If you're the average guy who could increase his income from $200,000 to $750,000 just for pushing the vaccines, I think you're crazy if you think that doesn't matter. Likewise, with the American College of Obstetrics and Gynecology or the Lancet or whoever it is, when you are looking at losing massive amounts of financial support, I think that makes a big difference. Roger Ailes, the former head of Fox News, said long ago that he really wanted to eliminate pharmaceutical advertising from Fox News, but they provided 70% of all of the advertising revenue for Fox News. So again, this isn't a partisan issue. This is when money speaks, unfortunately. So when you look at the financial incentives, I don't care if you're the University of California, San Francisco, looking at the data that was being thrown around yesterday with regard to cancer rates, they are heavily subsidized by the pharmaceutical companies. The media are, the journals are, and certainly the different medical colleges are. And I think that you cannot underestimate that.
So, and I certainly am interested in, support your skepticism, worry about the overreach of regulation and the pharmaceutical industry and how they're cozy. And this is all new information for me because I was, I still am ambivalent about it because I worked with pharmaceutical industries and professionals and have been very pleased with the work they do. But I understand what you're saying in terms of the adulteration of thought process. Well, here's where my thinking went in the middle of the night was, wait a minute. These were the same guys that told me that if I didn't follow the Women's Health Initiative in 2014, line and verse, I was no different than a witch doctor. Those were their words. And at the time I remember thinking, wait, something's wrong. Something's wrong. That's not right. That doesn't fit. That's not all these women I have on the hormone replacement therapy are going to be destroyed when I take them off. And then we were required to take them off. These women were destroyed. They went from elongated, upright humans to spheres that were in pain chronically from their osteoporosis. Then, 3 years later, they went, oops, we got that one wrong. I today spent about a half hour trying to find both that admonition about being a witch doctor and what they said when they changed course dramatically because that study was so flawed and no one saw it. Can't find it. The internet is scrubbed for that, which is very interesting.
Right. And the other thing is, I think there's a confluence of these forces, Drew, because back to your issue about the American College of Obstetrics and Gynecology, you've got the doctors at the helm making decisions and they know that their college is being financially supported by pharmaceutical monies, but they say, let's be real scientists. And they go instead to the journal. They say, well, let's actually see what the studies show. So they read a study that's corrupted, because it's also paid for by the same pharmaceutical company, but that study supports their behavior. So they legitimately have gone to the study. And this, as you know, for me has been the existential crisis. If you can't trust the studies, if you can't trust them because they were bought and paid for by the pharmaceutical company, so there's a confluence of all of these forces. So as you saw, that they led you to believe.
Yeah. It's even weirder.
They led you to believe you should do something.
And I did it, and it hurt my patients, and then I found out I was right. Now, the other circumstance in which every professional society in this country fought me was with the prescribing of opiates. Pain is the fifth vital sign, Dr. Pinsky. Pain is what the patient says it is. Pain control is what the patient says it is. You're going to be guilty of patient abuse if you don't give that heroin addict the Vicodin he wants, or whatever. That was the insanity that was going on back then. Same organizations, both situations, and same thing now. I'm going, something is not right. Oh, it's those guys again. It's the same professional societies, again, that got it so wrong. So then I started thinking, I got to figure this out. There's something wrong, and I can feel it. But go ahead. It might be money, it might be something else. I don't know.
No, and I do an entire presentation on the lack of critical thinking that has taken over medicine. Here's another, when doctors became entirely employed, and 80+% of doctors are employees now, either of a large hospital system, of a large medical group, or of an insurance company. And I'm here to tell you that you work for the person who pays you. And if you are being paid, if you work for an insurance company or a hospital system, you work for them, not for the patient. And you are going to do what they tell you to do. When I was working full-time at a hospital-based trauma practice, and they entered into and you got incentivized based on your Press Ganey results, your patient satisfaction survey. So here I am, a trauma specialist.
That's where the opiate thing ran amok.
Right. So I'm trying to save people from the clutches of death. These are people shot in the chest, horrific car accidents, awful trauma. And I'm trying to save them. And I need to worry about the patient satisfaction survey, whether or not they liked my bedside manner. I'm like, how about if I saved their lives? You might incentivize me on that, whether or not I kept them from the morgue. But no, instead, you're going to incentivize. So what do you think happens, Drew, when the mother comes in and says to the doctor in the urgent care, my child has an ear infection, or the doctor says you have an ear infection, which we know are 98% viral, but mom wants a prescription for amoxicillin. Okay, you're thinking, well, I can either weigh driving, bacterial resistance, antibiotic resistance, or I can make this mother happy, and my Press Ganey, my patient satisfaction, I don't care. I'm writing a prescription for amoxicillin, even though she doesn't need it. Because when you start incentivizing doctors based on the wrong thing, not following the best medical care, but making the patient happy, you're going to give them that prescription for Vicodin. You're going to give them the prescription for amoxicillin. They want a party favor, you're going to give them a party favor. That's not good medicine, but they set up the incentives that way. And doctors are humans, and they're going to, play to the incentives.
And then finally, I've been sort of obsessing about this one article in JAMA, which was, vaccinated pregnant women, unvaccinated pregnant women, and it showed a slight increase in benefits, NICU hospitalizations for the infants, less ICU visits for the mom, and except that there was a higher incidence of babies coming back to the hospital. These were slight differences in all these issues. And the thing I could not figure out, and I'm still digging into this and asking multiple reviewers to look at this with me to make sure I'm not getting something wrong, but I can't see that the change in the outcomes in the two populations was related to COVID. Their endpoints were just NICU hospitalization or ICU for the mom, not ICU due to COVID. I couldn't find it anywhere in the paper that they documented what was in the mix of these two populations, the vaccinated, unvaccinated, say mothers in the ICU. There's no criteria. There's no diagnostic information. It could all have been, I don't know, anything. Could have been any kind of misadventure in pregnancy. It doesn't have to have been COVID. And people are looking at me going, oh, you here to tell me that the vaccine made some sort of difference that wasn't related to COVID? That's in medical literature all the time. That's why we have to do RCTs, because the outcomes are very unpredictable. They can look all kinds of ways, and it doesn't have to be doing anything to have anything to do with the desired outcome of the therapeutic you're offering. And if people don't know that and understand that, it seems insane to suggest, well, you're telling me that's not COVID that made the difference when they gave a vaccine? It may be, but it may not be. And they don't specify.
No, there was a horrifically bad study. And as I said, you're pointing out one of the very obvious flaws. I mentioned yesterday that study was authored by two people who work for the Canadian version of the CDC, and a third person who works for Pfizer. Okay, so let's start with that.
I'm obsessing about it. So
I'm
obsessing about all this. I'm trying to figure it out. It's very disturbing to me. I got to tell you, I'm in like a weird. I agree with you, but I'm in this weird existential, weird.
But I'll tell you, and then before we
psychological
state. And I want to get to calls, but the last comment I'll make about this is I maintain that the fundamental construct that was violated is that we never, ever give to a group of people a therapeutic drug intervention in a group of people on whom it was never tested. These vaccines were not tested on pregnant women. They were not tested prior to being launched. And the idea of giving them to pregnant women is absolutely unconscionable. These are studies that will take years to figure out. There's a reason why vaccines take 6 to 8 years to come to market, if they ever make it to market, because you need to test it on people first.
Well, and this is what makes it so difficult. It is a moving target if you're trying to do observational studies, because the virus is changing, and so is the population that you're vaccinating. It's not an RCT where you start out with two controls and move forward. You're trying to do observational data on a virus that is mutating all the time. It is extremely difficult and inaccurate and full of confoundings, things. Okay, so what?
Time to talk about not COVID.
Okay.
Guys. I told you we had a hangover. We had a hangover from yesterday. Do you want to quickly go over Matthew Perry? You and I have not really ever discussed this together. Very quickly before we go to calls.
Yeah,
because I'm guessing you have some concerns that Matthew Perry might have something.
Well,
remiss, but I don't. But go ahead.
Well, I don't know him personally. I know only what I read of him, and he's was a very complex person with a storied history of substance abuse. So I have no idea what actually happened. One has to wonder anytime you see a previously healthy person who appears to be quite fit die suddenly. In today's world, you do have to wonder about the vaccine, but I would be crazy to jump to that conclusion given his well-known history of substance abuse and mental health issues and those sorts of things. So I don't know what happened with him. It's certainly, the question is out there, and until we have autopsy or are made privy to the results of said autopsy, I don't think anyone can say.
Yeah, I agree with you. A couple of things. They're reporting that no meth, no fentanyl, those were not his drugs. He was an oral opiate dude. He got probably in some benzodiazepines lately, which is very dangerous for somebody with his history, very dangerous. And he had COPD, I'm hearing reported from tobacco use. So he also might have coronary disease, right? So this could have been a coronary event. He played pickleball before. Yeah, who knows?
It's very,
but it is interesting.
It's very different, Drew, from the soccer player who has a sudden cardiac arrest on the field, or the 17-year-old who's found dead in bed by mom in the morning. That's very different. This is somebody whose history is quite complex, and there are lots of other things that could be out there.
I agree, and I just wanted to roll through that,
Yeah.
and except to just point this one thing out. My entire career, and I mean my entire career, when people came to me and said this young healthy person died, or had dehydration and died, whatever their little code was, or went to the hospital for
Right.
exhaustion and then
Right.
died.
Right.
100% of the time, it's addiction. Now I
Yeah.
stop and go, there's
Right.
some other options now, which is weird. That's
Right.
weird that I think that way. That's odd. All right,
Right.
let's do this. Let's take a break. Let's get the business out of the way, and then we will go to your calls. Non-COVID related calls, if we can limit it to that.
Please.
We'd be very much appreciated. So we can't seem to resist. So if you can, it would get us on course. So let's do business, and then back with calls. Susan and I have been looking for nutrition-packed, great-tasting greens drink for a while. And then we tried our friends at Paleo Valley's organic super greens, which is superior to what's out there on the market. Our friends at Paleo Valley, well, they think of everything, and they've created what's been called a magical green powerhouse. All three delicious varieties, pure unflavored, strawberry lemonade, and tropical, contain 23 certified organic, antioxidant-rich superfoods, including the highest quality spirulina. It's also free of cereal grasses, gluten, grains, soy, and dairy, and no added sugars or artificial sweeteners. And what's more, it delivers digestive enzymes, polyphenols, which are believed to burn fat, and 8 essential amino acids. Imagine the time, effort, and cost of trying to make this yourself. It's impossible. Head on over to drdrew.com/paleovalley, and you will get 15% off your first order. All the great products they have there, 15% off at drdrew.com/paleo, PALEO. Fall is right around the corner, which means dry, flaky red skin from allergy season is coming with it. But the best way to take care of your skin is with our skincare secret, Genucel. You don't need to worry about that puffy, tired eye look or those annoying dark spots or even dry, flaky skin, because Genucel skincare has you covered. Susan and I love our Genucel products so much, we want you to try our personally curated skincare bundles. It's risk-free at Genucel.com/Drew. Genucel works so well, you can see the results in this unplanned live moment on our show when the Redness Repair Cream repaired my skin in just minutes right before your eyes. Their concentrated vitamin C serum helps keep your skin plump and hydrated. Plus, with their immediate effects, you can see astonishing results in under 12 hours. Quick, effective, and easy. Go to Genucel.com/Drew right now to try our bundles and save over 60% today. And remember to enroll in Genucel's world-class concierge program for additional savings and free shipping. Don't wait. It's Genucel.com/Drew, GENUCEL.com/DREW. These products have transformed my life and Susan's and saved our marriage. Discover the key to oral hygiene, regardless of your current daily dental routine. Whether you diligently brush and floss multiple times a day, or you struggle, you got bleeding gums, bad breath, plaque buildup, this revelation is for both of you. Surprisingly, over 350,000 Americans experience health issues that may be connected to their toothbrush or even caused by it, ranging from heart or blood sugar problems, forgetfulness, digestive difficulties, immune issues, all related to oral hygiene. Scientific studies have shown that a simple switch of your toothbrush can lead to a healthier teeth and potentially save your marriage. Yes, save your marriage. Our study, we did a personal study. My wife, Susan, hates the sound of the sonic toothbrushes, but introducing the Real White Sonic toothbrush, of course, also their hydroxyapatite dirty mouth mineral toothpaste by Primal Life Organics, these products have transformed my life and Susan's and saved our marriage. It's much quieter. It's a very powerful toothbrush, but it is quiet and it saved our marriage. So, the Real White Sonic toothbrush from Primal Life Organics stands out among all other electric toothbrushes I've tried. It effectively eliminates plaque, harmful bacteria, promotes gum health. Get yours and enjoy 60% off at naturaltoothbrush.com/DREW. Some platforms have banned the discussion of controversial topics. If this episode ends here, the rest of the show is available at drdrew.tv.
There's nothing in medicine that doesn't boil down to a risk-benefit calculation. It is the mandate of public health to consider the impact of any particular mitigation scheme on the entire population. This is uncharted territory, Drew.
And there we have been since. Kelly, I just ran the latest New England Journal of Medicine, which just came out 5 minutes ago. Interesting article about SARS and early weeks of gestation causing situs inversus. That'll be interesting. Keep an eye on that.
Oh,
which is
also
Really?
on the
Interesting.
restream, they
Wow.
were mentioning how good Kelly looks right now, and I just want to give her a shout out. I think the Paleo Valley turmeric and Genucel's doing its job
There-
over
there
there.
you
So,
go.
and
There you go.
You're
Absolutely.
beaming. You're beaming.
Well, I
love
also
that
got a
stuff.
new computer, so I have a new camera. But I think it's the Genucel. I think it's the Genucel.
All right, James, unmute yourself there, and you're coming on up. James, go ahead.
Oh, how are you?
Hi, James.
Good.
Hello. Hi. Thank you guys for
Hey, we hear
everything
you.
guys are doing. Thank you guys. You're awesome. Listen, I'm reading a book, Eat to Beat Disease. I'm actually astounded how confusing the topic of nutrition is. To keep healthy and so forth is such a confusing subject. You know, you got Dr. Berg, obviously, she's got all these followers. What is your suggestion? I did get the spike protein. Thank you very much. I'm not getting into that area, like you said. Thank you very much for that information. What is your suggestion on what is a good nutritional foundational diet for people to live by?
It's a
Want me to
great
take a
question.
stab?
I'm going to throw you
Yeah.
back while we try to answer that. I will just,
Well-
I'm going to give Kelly a first slice of the first, what do the Europeans say, bite at the cake. But before that, I just want to say one thing, which is Kate Shanahan, who we've had on this show. She's a biochemist and she's a family practitioner, and she was the nutritionist and doctor for the Lakers for a while. And when I first met her, she goes, nutrition is too spectacularly complex for me to say anything meaningful about the biochemistry, except in very narrow areas such as healthy fats. And she had some very specific stuff about healthy fats, and we can talk about that. But in terms of, you should be eating X number of blueberries every day, or X number of, how much wheat, or but there are some general things I think both Kelly and I can talk about. So go ahead, Kelly.
Yeah, and James, first of all, I share your frustration with it because, again, the medical community has done a lousy job. We've ping-ponged all over the place. Eggs are good, eggs are bad. Cholesterol is good, cholesterol is bad. High fat, low fat, high protein, low. It's all over the place. I can tell you, this is a particular area of interest of mine, and I know a lot about it. I have come to the conclusion, after doing unbelievable reading of my own, that the best diet really is one that's, believe it or not, relatively well balanced. I think although you can lose a lot of weight on keto, or you can lose a lot of weight on, a low carb diet, they're not really sustainable for most people. I've come to the conclusion that processed foods, and particularly high sugar processed foods, are a problem because they're highly inflammatory. It's not sort of just because they cause you to be fat. Sugar by itself, and rapidly accessible sugar, processed sugars, are inflammatory. And inflammation, I believe, is fundamentally the key to most disease processes. We know that inflammation is a real problem, and cutting down on processed sugar is part of dealing with that. Americans in general eat far, in my estimation, too much protein. We have this idea that just because you go to the gym 3 days a week and lift some weights, that you need to be taking a protein shake and protein bars and additional. Americans eat way more protein than they need, and I think a diet that is moderate in protein, relatively high in good fats, meaning, your olive oils and your omega-3 fats that come from nuts and from fatty fishes and avocados,
Butter,
and those sorts of things
lard
are good for you. And then eating, a complex carbohydrates, really whole grains. So getting back to whole foods. And I think that's sort of, I guess that would be in a nutshell where I'd lead you.
Yeah. I agree. I think I would even add to Kelly's list, to the sugars, simple sugars, I would add starch. Pure starch is problematic.
Which is simple.
The quantities we take it. which is sugar.
Yeah.
Which is sugar.
Which is sugar. Which
I
means
sort of
your,
feel like
your white
if-
flours and white rice, that kind of stuff.
Yeah. If anything has the consistency of cake, even if it's bread, or if something is really sweet, easy does it. easy.
Yeah,
If it tastes good.
The other thing I'm going to throw in there, and I think it's really, I've done it in the past probably 4 years, a lot of research on this, is this concept of fasting. Sometimes, intermittent fasting. There's no question that the problem in part of the reason I believe that we see such high disease prevalence in Western countries and in wealthy countries is because we are the people who have access to food all the time. In other areas that have lower disease states, they go for longer periods of time without eating anything at all. The average American eats his last bite of popcorn or pretzels or ice cream at about 10 o'clock at night, and then eats breakfast sometime between 6 and 7 in the morning. So the longest period of time they go without eating is maybe 8 hours. That means you are constantly providing sugar to your body, and you are not promoting things like apoptosis or autophagia, which is the body's, those are fancy words for the body's normal process of clearing out dead cells, clearing out the debris. Fasting, even for short periods, 12 or 13 or 14 hours, meaning, maybe from 8 o'clock at night until 8 o'clock in the morning, or, 6 o'clock at night until 8 o'clock in the morning, that promotes your body. It puts some stress on the cells, and it allows your body to do what it does under stress, which is go in and clean up the dead crap, clean up the stuff, the cells that aren't very useful anymore. And that also happens to mean cancer cells that have mutated. So I think that the idea of doing some element of intermittent fasting, meaning at least making yourself eat in a shorter window, maybe a 10-hour window a day, does show some benefits, and the benefits are really quite profound.
Agreed. And a couple other things. When we say inflammation, we're not really talking about the kind people think immediately joints and skin, and we're not talking about necessarily, though some people do get some benefit, the kind of results you see with rheumatoid arthritis or something like that. We're really talking about the endothelium, the way the body clears the immune system, the way it delivers blood. It's a very complex. We don't think of it as an organ system, but our arteries are lined by an organ system, and that organ system interacts with the clotting, the lipid, and the immune system. And as such, it can be very much affected by what Kelly is talking about. The other thing, a friend of mine, Peter Attia, who's really one of the best longevity experts I think out there. I was sort of, pimping him one day. I was like, what about this? What about that? What about metformin? And he looked at me, he goes, look, vigorous exercise. That is the most significant benefit for longevity, and not just longevity, but pushing back that cliff of aging. I forget, he has a name for it, but you and I, Kelly, have seen it, without exception. It happens to everybody if you live long enough. Right. And if you can push that back really into your 90s and maybe have a way to kind of manage it by not losing too much muscle mass and maintaining your balance and keeping the nutrition up, you can live well into your 80s. And then
mention V-Shred.
Well, V-Shred
I used to do the protein bar diet, Kelly, with the keto.
No, hang on, but Susan,
it was so hard.
But Susan, the losing weight on a prescriptive diet is not what the question was. The question is, what is a healthy diet, which is a different question. If somebody really has to lose weight, we go to great lengths. We do surgeries, and we use Ozempic, and we use all kinds of unhealthy stuff to get them to more towards a healthy chronic state. But yes.
But isn't that what it means to be on a healthy diet, to get your weight in the right place?
It's like,
losing
for instance,
weight.
Go ahead, Kelly.
Yeah, and it was to say losing weight and maintaining, and what you were just saying, it's really hard. That's the point. That was my point, is that although you can lose weight and should, if your weight is above the ideal zone, then you definitely need to get it down, because there are innumerable health benefits. But the problem with people trying to stay on these keto diets, for example, is it's very difficult, and you end up instead binging. What we see is a lot of people, you eat no carbs, and then you eat the entire package of Oreos. And that is, no, I mean, truly, I mean, believe me, I've tried,
I know.
it happens to all of us because those cravings, so you're better off, I believe, in managing your blood sugar regularly by eating a moderate amount of complex carbohydrates rather than trying to restrict them entirely.
Yes.
And keeping in that zone, because you really want to avoid those sugar binges because they're highly inflammatory. It's that endothelial inflammation, and we know that it drives not only heart disease but also cancer growth.
And Susan is referring to a program that we've been pushing that we have found. I've lost 14 pounds on. I've found much better for my joints and appropriate for my age. This V-Shred platform, which has different cost-effective ways to manage these things. It's like having a virtual trainer, and I loved it. So I signed up.
Right. I didn't have a lot of weight to lose, but I was having a problem. I was getting closer, like 10 pounds over my comfortable weight. And I always would have to go on like Lindora or something and do the bars and the protein.
See, that's a
blah, blah,
therapeutic
blah.
intervention.
And then, or whatever, do keto and I swear it was just so hard because I gained the weight back. And
that's the other
time
thing
I've been able to keep it off.
Research shows that people rebound above where they were.
Right.
But the other thing, one last thing about the intermittent fasting, I'm not totally sold on intermittent fasting, except there's one aspect of it that no one talks about. And it's an important topic generally, which is appetite management. Your body tries to stay where it is, wherever it is. If it's way up, if it's way down, it tries to stay there. And it will fight you. And intermittent fasting does kind of help appetite management, in my experience, in the earliest parts of a diet.
Oh, I think there's no question. And I am truly a huge believer. If you look at the results on insulin resistance, it's one of the best ways to reverse metabolic syndrome, Drew. And there are lots of ways to do it. I live by the 16-8. I eat in an 8-hour window every day. It's, I eat generally between noon and 8. If I'm going out to dinner and I know I'm going to be eating dinner and not finishing until 9:30, then I don't eat my first meal until 1:30 or 2 in the afternoon. I eat in an 8-hour window. So I go 16 hours a day with no food, and it really markedly improves your insulin metabolism for certain, but it also controls cravings, as you said. Some people choose to do it. You can do 2 days a week, 2 non-consecutive days a week where you fast, where you only eat 500 calories, say on Mondays and Thursdays, and the other days of the week you eat normally. The idea is that by depriving yourself of food for a period of time that is longer than the average 8 hours, you put that stress on your cells on purpose because it motivates them to go into autophagia and apoptosis, where you're cleaning up dead and really or malfunctioning or dysfunctional cells. And I think that the data, to me, that the research is really pretty overwhelming. There's a guy out of USC who wrote the book on it, Walter Longo. People might want to look at that. Walter Longo, Valter. Longo, who's written extensively on the benefits of fasting, and it's worth looking into.
Yeah. And again, the diet you'll do, the exercise program you'll do is the best plan for you. Try experiment with things, but the one you will do, the one you're willing to do, the one you enjoy.
Yes.
I mean, particularly with exercise. I
remember when the kids went to a nutritionist, and it wasn't, you're going on a diet. It's like, we're going to teach you how to eat healthy. Like, this is just like how you're going to, a way of life.
But there's different ideas
and
about
once in a while you can have a cheat day, whatever, but they would lose weight because they weren't just eating the
junk.
The most
Hunter,
thing.
unmute your mic there, and let's have at it.
Hey, Dr. Drew and Dr. Kelly Victory, how are you doing?
Good,
We're
thanks.
Good. Welcome.
Awesome. I actually had a question for you regarding the shooting in Lewiston, Maine, if that's cool.
Sure.
Please.
Absolutely.
Okay, cool. So I just wanted to ask, so this horrific shooting and the individual involved, it said that he was in a mental health hospital over the summer for about 2 weeks. I guess my question is just simply like, what sort of treatment do you think he received there, and why did he come out still a danger to society, or possibly even more of a danger to society after that situation?
So, Hunter, what would you know what the diagnosis was yet? Have they told
Yeah.
us that? I've heard various things flying around. Do you know?
Well,
I do not know.
Kelly, do you?
Yes. Well, I've read was reported is that he had a quote history of schizophrenia.
Uh,
You might, yeah. So my concern is this, clearly he had a long mental health history. It had gone on for a long time. And you're correct that he had been hospitalized. Schizophrenia is extraordinarily complex and difficult to treat. And it is unlike trying to treat someone for depression or anxiety, where you don't reverse it. You can control schizophrenia. It's not, it's not curable in the same way that we can get somebody who was depressed to treat them for depression and they may go forward totally normally. I have never in my history, I was a psychologist before I was a physician. I never cured anyone of schizophrenia. So, Drew, you weigh in on this, but I suspect that he remained susceptible to a psychotic break.
Oh, for sure. And there's different qualities and kinds of schizophrenia, and some are more intense and worse and more difficult than others. But Hunter, this is where my concern is. I worked in a psychiatric hospital for 30 years. And I saw our ability to help these patients eroded systematically by the law. The fact is, the earlier you intervene on a schizophrenic patient, the less severe the course of their disease, and you can often restore them to a productive life. And if you do not treat them, they decay systematically and are irretrievable. One of the most bizarre qualities we have in our law, particularly in California, is if you don't treat a dementia patient and you let that dementia patient run around in the street, you are guilty of patient abuse. And yet that dementia is going to progress no matter what the doctor does. That person is going to it's going to progress. While the schizophrenic, if he or she says, I don't want anything to do with you, I'm Napoleon, you're not allowed to go near them. You're not allowed to help them, and they will deteriorate over time to the point that they will never get better. Not only that, there are long-acting antipsychotics that are extremely effective if we are allowed to give them to these patients. And cognitive behavioral therapy does great guns once their psychosis is under control to help them identify and see their delusions and their hallucinations so they can identify them and distinguish them from who they are and what reality is. They can do it cognitively, but you have to intervene on these cases or they deteriorate to the point, just look out on the street. There's just so many people out there. In California, there's tens and tens of thousands.
Right. I mean,
so
much
that's
of our
that's my public service announcement about the case. We don't know much obviously we don't know the details of this particular case, but my bet is 2 weeks is reserved for the most seriously ill. If you get somebody and you're able to lock them up 3 days, lock them up. Keep them under supervision for 3 days, and then extend that 2 weeks. You have to have a court come in and commit the patient. A judge has to come to the hospital and commit that person to 14 days. After that, it's conservatorship, and you can never get those, although they've expanded that a little bit in California just recently. So my fear is that this poor man didn't get the help he deserved because of the laws.
Yeah, and again, I don't know a tremendous amount about this individual other than, as I said, that he had a history of schizophrenia. But the reality is what Drew is saying is spot on. Much of our issue with homelessness, drug addiction, all the crime, frankly, has to do with the deinstitutionalization of people who should have been really locked in mental health facilities to get the care that they needed, but they weren't. We had a massive deinstitutionalization in the United States in the 1970s. Those people, instead of actually being remanded to care, were put out on the streets where they are now creating, not only living horrific lives themselves and dying of drug overdoses and dying of malnutrition and as victims of crime themselves, but they are perpetrating the crime and they are leading to the huge explosion that we have with homelessness.
and we're using words like locked up and stuff. Look, the psychiatric hospitals now can be social models. They can be the Trieste model. They can be beautiful grounds and facilities and vocational rehab and social structures. And I mean, these can be halfway houses that move people towards independent living. The fact is, in your head about what Kelly used the word institutionalization, and I used a casual word locked up. In your head, you're thinking about Ken Kesey and One Flew Over the Cuckoo's Nest. Number one, that was not a documentary. That isn't what psychiatric hospitals were like even then. Number two, that was nearly 70 years ago that was written. We're approaching 100 years since that book was written, and things are very different now in terms of psychiatric care. It's much more humane, and it was never quite like that in the first place. So that's our little public service announcement. Hunter, is that helpful at all?
Yeah, and I appreciate you saying that. You know, I myself have bipolar disorder with psychosis, and I've been in psych hospitals, and I've been court ordered in there and shit. So I know how it goes. And I think also what you touched on with cognitive behavioral therapy is really important, because that's not something that you get taught overnight. It takes a long time to work on it.
That's right.
You know, and you can't do that over 2 weeks. You can't do that if you're not getting the resources that you need.
Right.
Dude, that is so profound and absolutely true. But not only that, is that done properly. Again, this is 2000. We're into the 21st century. Psychiatric care is totally different now,
right?
And treatment tends to work. It works if you can get people and keep them long enough to do the treatment. And so, Hunter, thank you for saying that. I really appreciate it.
Totally. Thanks so much for your responses. Appreciate it.
All right, you bet. I mean, it's a complicated topic, and it's one I'm very, very frustrated even talking about because, I having worked in the psych hospital for so many years, I look out on the streets and go, oh, those are my patients. I could help these people. I could easily help these people. It's not that hard. You just need to, I know exactly how to structure a program. I know how to staff it. I know how to manage it. I know where to put them. I just know what to do. And you're not allowed to. You're not allowed to. So you're running an open air hospital without doctors and nurses.
Right.
That's the insanity. Social workers, as wonderful as they are not medically trained. It's like literally asking asking a physical therapist to do orthopedic surgery. That's not their training. Right. And social workers are not trained to take care of medically sick brain disorders, medically relevant brain disorders. Anyway, so that's my public service announcement for the day. Okay. We got a few calls here. I'm trying to get to people. There you go. This is Megan. Looking at how we're doing on time here. And let me also look at what's going on in the chat room. Susan, anything in your chats and the Rumble?
I was just telling Emily that you're going to do Russell Brand's show next week.
Yes, I am.
Sorry, I don't know when I heard you in the background.
I don't know when it's going to air, but I do know
I think it's live.
Is it? I don't know how that works. And he and I have done public stuff before.
Because they always have people talking on his stream.
Okay.
So I think it's a live stream on Rumble and Twitter. He goes on YouTube and then he shuts it off because he hates YouTube like we do. Okay. And then he sends everybody over to the other platforms. And then I think he's on Locals as well.
Okay. Any event, he and I have done public events
Tuesday or Wednesday. I'm sorry.
Thursday.
I thought it was Wednesday.
Thursday. He and I have done public events about, let me double check that. I'm going
to
Here we go again.
Now.
Wednesday's my day. So
it's not this Thursday. It's not tomorrow. It is next Thursday.
It's Thursday.
Schedule,
okay. All right. See, look, that's why I have you around.
So Megan, you have to unmute your mic there per Caleb's little cartoon.
Hi, thank you so much for having me.
You bet, of course.
Hi, my question is about SSRIs. I listened to an episode of your podcast a little while ago where you spoke about SSRIs, and you were talking about how some people are experiencing sensitivity issues with coming off of SSRIs. I recently came off of SSRIs after 9 years.
Yes.
And I'm doing fine. I'm doing great. I'm wondering if your attitude towards SSRIs has changed with some of the recent news that's come out about them.
Which particularly are you thinking about?
I just got off. So I was on for 9 years.
No, you said recent information. about SSRIs? What particularly were you thinking?
It was about the sensitivity issues that were coming
Oh,
off of
those issues.
withdrawals.
Yeah.
Yes.
So look, we over-medicate people and we under-medicate people that really need it, frankly. That's and when Sigmund Freud got to America, you'll appreciate this as a psychologist, Kelly. He arrived at the dock and the reporters threw microphones in his face, said, "Dr. Freud, what do you hope to achieve here in America?" And he said, "Well, I hope to come to an understanding of the difference between true psychiatric illness and ordinary misery." Okay? Ordinary misery is something we have lost track of in this country and we do not tolerate. Ordinary misery does not have to be medicated. And we tend to medicate it. Primary care doctors tend to medicate it. And you as a psychologist and me as somebody working in a psychiatric hospital know, woefully inadequately trained to be doing that. People are left on them for too long. And and I've seen lots of withdrawal, Megan, the withdrawal syndrome. I've seen it from Zoloft, from Paxil, from Effexor, from Cymbalta, which is a very uncomfortable zapping, feeling up your neck and into your head. And it can go for, I had one person, I had one person that was on 8.75 milligrams of Effexor, which is like the tiniest crumb of the tablet, and I could not get her off that, and she just stayed on it because that withdrawal was so awful. So there's withdrawal. There also are sexual side effects, which is something I've been campaigning about for 25 years, even though the companies originally denied it, back to the concerns about pharma. Look, I had a Xanax rep, an Upjohn rep, come in my office and tell me Xanax was not addictive in 1989. I'll never forget it. So don't even, and by the way, 5 years later, I had OxyContin reps in my office saying the same thing. I was like, get out of here. It's just, I can't even talk to you people. So the sexual side effects are profound, can ruin relationships. They can affect any phase of the sexual response cycle, from libido all the way to detumescence. It has any cycle. Now, this podcast I did was about an organization of patients that has gathered together who have persistent sexual side effects after they come off. And it turns out that's a bigger problem than most people knew, than I know. There was a psychiatrist that was sort of in charge of that particular conversation I had. He believes, I actually don't buy this, he believes there's a neuropathy that develops from the SSRIs because there's sort of a numbing of genital responsiveness. I don't know that that's it. To me, it just seems we should be able to document that if that's what it really is. But suffice it to say, it's very unpleasant. It is persistent, and there's very few treatments for it. So it's like any medicine, Megan. Medicines are not all good and all bad. That's why I'm so deep in the discussion about vaccines and things. All medicines can be very helpful in certain situations and very problematic in others. Same medicine. And that's what people they can't seem to hold these ideas in their heads simultaneously. So like every medicine, the SSRIs, I've seen it save people's lives. I've seen it destroy people's lives. That's on us. That's on the practitioners to get it right. We're supposed to be able to do that so we do no harm.
Right. And I think the thing that I would pipe in here and say is less about specifically SSRIs and this issue of that we over-treat what is, I think, situational and life-related depression, anxiety,
ordinary misery.
Correct. If you look at the three most commonly prescribed drugs in the United States, they're statin drugs for high cholesterol, drugs like Lipitor, Prozac, and sleep medications. We are the wealthiest country on the globe. Okay. Why is it that no one can sleep and everybody is profoundly depressed? All right. And I would submit to you that they aren't. We are not teaching people how to deal with anxiety, regret, rejection, failure, loss. I'm not talking about people like our last caller, like Hunter, who has, bipolar disease, or somebody with schizophrenia, or somebody with psychosis, or with somebody with an organic depression. I'm talking about that every kid right now is on Ritalin or Adderall for their, for their inability to concentrate. Everybody and their brother is on Prozac or an SSRI or some sort of treatment for their anxiety issues or their sleep issues. And I think, I'm not saying that these diseases don't exist, but that we are painting with a very broad brush who needs to be medicated without trying the things that take longer. It's a lot easier for a doctor to whip out the prescription pad and write a prescription than to sit
back
down
to the
and do
patient
cognitive
satisfaction stuff
therapy.
too.
Correct.
Yep.
And to actually sit and talk with people, to do cognitive and behavioral therapy, talk about really how to it's treating someone for a phobia. And I know how to do this. I mean, there are ways you treat people behaviorally for phobias. It's a lot easier to whip out a prescription pad and give them a prescription for Xanax so they can get on the airplane rather than actually dealing with their phobia of flying. But I would submit
Back to who you work for,
that,
Kelly. The insurance companies reinforce that, and not either they either positively enforce it or they punish if you don't do it. So it's a mess.
So we end up with people on these medications that are not devoid of side effects, and they certainly aren't devoid of effects when you try to get off of them, because the withdrawal is very, very real, whether you're talking about benzodiazepines like Valium and Ativan or SSRIs. All of them have, God knows, opiates. You try to get off of these medications once you're on them, and I would submit to you, there's a reason that they haven't worked those kinks out, because it's in the pharmaceutical company's best interest for you not to get off of them.
So there you go, Megan. Any follow-on for that, or do you want to tell us about your position on all this? That's ours.
I was on SSRIs for 9 years, prescribed by my general practitioner. I was in my mid-20s and, going through a lot of life change. I, in retrospect, probably didn't need the dose that I was on. And actually coming off of it was quite difficult because my doctor convinced me that getting off of it would be dangerous. And
were you suicidally depressed when you first went on them, or something that makes depression dangerous?
When I first went on, yes, but I hadn't been that way in a very long time. So,
and let me state, if you don't mind, that there's about if indeed he was accurate in his diagnosis of major depression back then, if that was true, I mean, you might have had that, right? There's about a 50% chance of recurrence, but you should be off antidepressants in the meantime. You should give yourself a chance to live, and who knows what circumstances were coming to bear when you're a young adult teenager.
Yeah, I got a second opinion. And I just said, I don't want to be on this anymore because I just felt like I was chained to it. And I didn't feel that was necessary at the time.
Good for you.
Good for you.
Look,
things are good.
You're better off. This is sort of something that Kelly and I are obsessed with lately, which is getting the locus of control back to the patients, because right now the doctors have lost it. They're employed. Insurance companies the insurance companies, their employers have taken their ability to practice medicine away. So we need to get it back to the patients so they can demand proper care from the doctors. And we live in a time when there should be access by multiple means. We have so many options now with the internet, and it's just we got to build this system out, is what I'm saying.
The other thing I would submit to you, and I think I think it should be really common practice. I don't think a physician should be allowed to prescribe a psychiatric medication, whether it's an antidepressant or an anxiolytic, without having concomitant treatment, other treatment. If you are on an antidepressant, just the pill.
Yeah.
We are simply acting as if we can treat this mental health issue with a pill, and that there's nothing else that should go along with it. That's ridiculous.
But good luck getting
insane.
insurance to pay for the proper care. I mean, every study ever done shows the optimum method is medication plus talk, medicine off as soon as possible, continue talk. That's it.
Right.
That's optimal.
Exactly. So if you are treating your anxiety with a pill and nothing else, you are being mistreated. And unfortunately, as Drew is pointing out, the system drives it that way. But it's wrong. It's malpractice in my mind.
Herb Green there has a comment about his brother coming off Xanax. Yeah, at the time at which the Upjohn rep was telling me that my patient wasn't coming off Xanax, she was having a seizure that day.
Right.
And his point was, she must have an underlying seizure disorder, or that's just her anxiety coming back. Well, okay, people are really responding to the benzo thing. Benzo epidemic is the one thing left behind. We are on to the opioids, but I'm telling you, benzos are still there. And, we'll find out what happened to Matthew Perry, but odds are benzo plus opiate. That's the odds. We don't know. We have no idea, but the odds
plus
are
minus
that
alcohol.
Prince didn't die because of an opiate overdose. He was on chronic opiates for a long time. He died. He stopped breathing when they added the Xanax in. That's when people stopped breathing.
Yeah.
So anyway, Megan, I'm going to toss you back. Okay.
Thanks so much. Bye.
Okay, you got it. Good luck with everything. Oh, this stuff makes me upset. I end up upset with some of our stuff here.
I know.
Okay.
It's nice to be talking about something other than COVID, so I'm liking it.
Yes, it is really nice, isn't it? I really do dig it. Okay. I don't know if Fight for Freedom has got a medical question, but I'm hoping so. And we are running a little low on time here, so Fight for Freedom, unmute yourself there.
Hi, Dr. Drew and Dr. Kelly. So my name is Ginger in real life. A couple of things. First, I want to say thank you for your show. I've been following alternative media since right before COVID, probably. And just quickly, Dr. Drew, I want to say it has been a fantastic experience watching your progression through this whole thing. To see how you've come along to Dr. Kelly's side, I guess.
But it's all been a struggle. Understand? You're saying progress. I call it struggle. I'm still struggling.
No,
Kelly's not struggling. I'm struggling.
I'm
Kelly's
pulling
clear.
him.
I'm not clear.
Him over.
No, I can see the struggle. Like I can see the struggle, and sometimes I listen to you and I go, "Oh God, Lord, just let him get there a little faster. He'll get there. I know he will." Yes.
If it's the truth, if it is the truth, I will get there, Ginger. I promise you.
Yes.
It's just that
sir.
The truth is not always. I'm cautious. I'm super cautious, and I know it's frustrating for everybody. It's frustrating for everybody. It's for people I work with and stuff. But I'm still very cautious, and I go back and forth. I fluctuate. I don't like last night. I was like, oh my God, I am so wrong. I got this all wrong. The professional societies have it right. I was there for a couple hours last night, so I go back and forth.
Yeah, I think that you should just stick with your gut. I don't know if I was thinking this last night while I was listening to you guys talk. If are you talking to me right now? Because I see your lips moving, but I don't hear you.
No. Keep going. You keep going.
Okay. So last night when I was listening to you, what really came to my mind is that, you guys talk about spirituality, and I know Dr. Kelly is a Christian. I don't know exactly where you stand on that, but I feel like if people were to turn to God, they wouldn't be as confused about what's happening, because it's hard to realize the true evil in the world. And I truly believe the evil is there, and it is. And if people found God, they would be able to see it more clearly. And
well, Ginger,
that may seem simplistic,
I tell you what I have been thinking about. I believe that's fine, and I'm delighted when people feel that way, because I've seen it help people, and that's what I'm interested in, is helping people. I have lately been thinking a lot about vice and why religions are so tight on vice. Like I said, I'm obsessed with the French Revolution, when vice and libertinism was out of control. I think you end up with injured children, and therefore more personality disorders, and therefore more aggression and violence. I think that's kind of how things turn. I don't know. I might be wrong, but something along those lines. So, to the extent that it helps people live a good life, I'm up for everything. I'm up for anything.
Yes. And I have to say this. So you got, oh, sorry, Dr. Kelly.
No, go ahead. Finish your thought there, Ginger.
No, what I was thinking is two things. So you guys are talking about opioids, and you were talking about antidepressants. I have been on opioids for 20 years. It started when I was in the military. And it was like, oh, well, we can't find anything else to do for you, so let's just give you these. And
do you had chronic pain?
that has been yes, I have chronic pain.
Okay.
But
Are you still on
I
opiates?
feel like I am. I take Dilaudid, 2 milligrams.
If you can, Ginger, listen to my words. Do with it what you will. But I have seen so much improvement in chronic pain patients who switch over to Suboxone. There's been a lot of resistance for that, but literally every case I have suggested do this. They have been their pain is better controlled. Their sense of desperation and irritability and sleep all gets better. All those things you're kind of struggling with, I'm sure right now, because that's what chronic opioids do. It all gets better, and you still have something that has a great deal of analgesic activity. In fact, it's about 20 times stronger than morphine. So just kind of file that away. Talk to your doctors about it, okay? I'm not telling you what to do, but I'm just sharing my experience with you, okay?
Well, no, that's good, because honestly, I was on a bunch of medicine a year ago, and antidepressants was one of them. I got off of everything myself except for the opioids. And part of it, I know this about myself, is fear. I am fearful about getting off of them because if I don't have them,
understand that's a pathological fear. That people that are opiate dependent have particularly if you're on any methadone, people develop a pathological, overwhelming sense of fear. And then when they are coming off for the first 3 days, an overwhelming sense of desperation. And no one tells you about these experiences, but that's part of the deal. Now, it may not be realistic for you to come off everything. That's why what I do, I made my program, that's all we did was got people with chronic pain off opiates, and their pain magically got better. That's not everybody. You have to select the right patient for the right treatment. So you can certainly go try abstinence-based treatment if it's carefully managed. It's a little dangerous, or talk to your doctor about Suboxone. That's be my recommendation for you. Sharing with you my knowledge. I'm not telling you what to do. This is not practicing medicine.
No, I think that's a great idea. I wanted to be off of the opioids by the beginning of summer. And that didn't happen. And a lot of it, like all of a sudden I started my pain got worse. And I'm like, is this something mental? Because I'm thinking about getting off of the pain medicine.
It could be, so two things, and I'm going to put you back in because we're running out of time here, Ginger, but let's listen carefully here. Two things. The chronic opiates, not Suboxone, interestingly, chronic short-acting opiates like Dilaudid cause hyperalgesia. They make all pain more intense over time. So pain is amplified by the opioids over time. Secondly, they send you into states of chronic withdrawal. So the headache and the back pain that you no doubt are also experiencing, because everyone does, is actually a withdrawal symptom chronically from the opiate. On the Suboxone, that goes away, and in abstinence, that goes away. Kelly, we are down to our last minute here. Do you have anything to tell Ginger?
Yeah, the only thing I was going to say is I would just pipe in briefly on the whole issue of religion and spirituality. And I am never one to proselytize. I happen to be a Christian, but I think the reason that I think faith is important, whatever your faith is we have become a profoundly self-centered society. And the concept of something greater than yourself, a being, a force, a spirit that is greater than you, that oversees everything, I think is critically important to keep people from becoming more and more self-centered. And for me, it has given me great strength because I know that I can count on that greater force. And for me, it is God, to whom I can look and I can give over some of the weight that is going on in the world. Otherwise, so I'm not fighting this alone. I'm never alone. I'm not fighting alone. And that gives me great strength. It allows me to keep from, internalizing fear and anxiety and these things. And I think much of the fear and anxiety and sleeplessness and drug abuse and things that we are seeing is because people are taking it all on themselves. They feel the weight of the world on their shoulders.
And
and I don't.
they're
I give mine
grandiose
over to
caring,
God.
grandiose sense of control, grandiose sense
Yeah.
of everything being dependent on us, and the phone reinforces all that, the craziness on
Right.
social media.
Exactly.
And the fact is, it's getting out of your head, letting up on control, having some sense of something greater than yourself, whatever it is, and look towards empathy
I agree.
and gratitude. Other people, in my world, that's a big piece of the spiritual. So thank you, Kelly. Susan, you came running in here. Did you have something you wanted to say?
We have a fun night at the New York Comedy Special, which, Drew's really good at promoting.
I'm really
Just
bad.
Yeah, no, okay.
So there it is. Drew.com/New York Comedy, NY Comedy. It's me, Kat Timpf, Jimmy Fela. Jimmy,
shit, my phone.
whoop,
Sorry.
what's all
Sorry,
the
my
echoing
phone
about?
was on. Sorry.
Okay. I believe Jimmy Fela is going to swing by tomorrow and talk about that. Is that
Yeah,
true?
so Monday,
Okay.
November 6th,
Mhm.
if you're in Manhattan and you want to see Dr. Drew,
Mhm.
you can come to the Chelsea Music Hall at 8:30 p.m. and ask him your questions in person and laugh a little bit with our friends who are very funny.
Kat Timpf and Jimmy Fela. And I'm going to hang out a little bit there. So if you want to ask specific questions, there's time for that. So
Yeah. So anyways, I don't know if anybody's from New York,
There they
but
are.
we'd love to see you. It's a Monday night. You probably don't have much planned at 8:30. So come on down. They
It's a cool club. It's a cool little new
New York
club.
needs us. They need us. So we're going to try to have some fun.
All right.
Oh, and by the way, if you want to get 50% off your tickets,
Mm-hmm.
because you watch the show, just use the code word Drew.
There it is. He has it up on the screen there.
And your ticket will go from $30 to $15. So
Not
it's
bad.
cheap enough, and you can get dinner too.
There you
beforehand.
Use that code word for the friends we're buying tickets for, Susan.
Don't worry.
We're bringing people in. All right. So we thank you.
I know we have so
Okay.
many comp tickets and nobody's buying any.
I'll see you on
but no,
I'll
we
see
do
you on
wanna-
Tuesday.
We do want to see y'all there.
Yeah, let's talk about that. Let's talk about the schedule coming up really quickly. Caleb, can you put it up there for us? We have,
I
because
think
we're
I'm-
on the move a little bit next week. We're going to try something new on Wednesday and Thursday from Austin, Texas, which will be very interesting. We have a new studio that we're going to rent and stream to you guys. And Kelly, you'll be on the Wednesday show. Is that correct?
I think I'm on Tuesday and Wednesday. I'm not looking at my calendar.
Tuesday and
so
Wednesday. And
I
Tuesday
I think
is early.
I think I'm. Yes.
Also, unfortunately, I
exactly.
don't
We've
have
got
the
some-
full schedule set up here. All I have is the schedule of tomorrow's show that's coming up, which is callers on any topic, including COVID, but any topic, anything that's been left over, they can call in tomorrow.
I'm getting tired of COVID. No, wait a minute.
But we've got we've got
November-
an earlier show on Tuesday, which I believe is the 7th. We are at
Yes.
11:30 in the morning Pacific time to accommodate.
I think it may be noon.
a guest.
It may be noon.
Well, yeah, it's
it may be
earlier.
noon, and it's a very interesting
We post
guest.
everything on Twitter. If you're on
Yeah,
locals,
she's
I
from the
would send an
UK.
email out.
Yeah, I think
can
it
do that.
moved
Did
from
she,
11 to 11:30. It's
I think I can
11:30.
say it, can't I not? Can I promote it a little bit, who it's going to be? You
Yeah,
think?
yeah,
Yeah.
I think
Okay,
so.
It's Christine Anderson. Yeah, Christine Anderson. You may have seen her. She's had some very, very strong videos running around, and I asked our crack booker Emily Barsh to get on that, and she was like immediately
Yeah.
booked. And so we're
Yeah,
both,
yeah.
and Kelly said she'd like to talk to her too. So we said by all
And then we're
means,
going to try a new studio
Absolutely.
in Austin
on Wednesday and Thursday.
on Wednesday and Thursday. So
we'll be in
we'll
New York on Tuesday. We got a lot. Because
we're
doing
moving
that.
all around. Drew can't help himself. He has to book stuff.
It's your comedy show.
We're
Your
in one
Monday
city,
show.
and he's got to go to another one the
It's-
same week.
It's your Monday show.
I'm tired, Kelly. We've been traveling so much.
Guys, it's
I
really
hear
sounding
ya.
like we're going over the schedule again at the end of the show, like we never do.
Yeah,
All
Yeah,
right,
I
we're gonna
know.
stop.
But we want
Okay,
everybody
let's
to
get back to
tune
the
in
baby.
because
Come on, guys.
Caleb has baby.
Caleb,
we
get
need you
back
to
to the
tune
baby.
in and support our sponsors so the new baby has new shoes.
There you go.
There you go.
There you
They
go.
All
always
right.
need new shoes.
Oh, she's
There she is.
adorable.
That's our sweet little Presley.
That's awesome.
Yep. All
Congratulations.
right, you guys. Thank you so much for being here today. Thank you, Kelly. I'll see you
guys
on
did it?
Tuesday at noon Pacific.
See you on
and
Tuesday.
be from New York. And Caleb, have a nice weekend with. Oh, I'll see you tomorrow. See you guys tomorrow it's early tomorrow, correct? Early at noon.
Yeah, because we're tearing down the studio because I'm remodeling.
We're actually going to make this look better for everybody. So yes, that is noon tomorrow. I will see you then. See you tomorrow.
Ta-ta.
Ask Dr. Drew is produced by Caleb Nation and Susan Pinsky. As a reminder, the discussions here are not a substitute for medical care, diagnosis, or treatment. This show is intended for educational and informational purposes only. I am a licensed physician, but I am not a replacement for your personal doctor, and I am not practicing medicine here. Always remember that our understanding of medicine and science is constantly evolving. Though my opinion is based on the information that is available to me today, some of the contents of this show could be outdated in the future. Be sure to check with trusted resources in case any of the information has been updated since this was published. If you or someone you know is in immediate danger, don't call me, call 911. If you're feeling hopeless or suicidal, call the National Suicide Prevention Lifeline at 800-273-8255. You can find more of my recommended organizations and helpful resources at drdrew.com/help.
Gilbert Gottfried got canceled for tweeting about the Japanese tsunami. I promise you, there was no one suffering from the horrors of a tsunami that was checking American Twitter.
When you're getting your instructions to go home, what are they emphasizing?
Do not attempt to penetrate stoma. And it happens often enough that they need to underline it, bold it. Cap tells you everything I think that you need to know about men.
Yeah.
Because there was enough people being like, okay, I just went through this traumatic experience where my intestines out, and then my partner put his dick in it.
The one thing you must be is funny. You better be funny. All right, here we go. Drew and Booth Boys, it's for you guys too. I had a hydrocelectomy. Do you know what a hydrocele is? No.
Is it an animal?
No, it's a big cyst in your testicle, should you have testicles.
Yeah, no.
Over a cup and a half of fluid drained from my right ball. Maybe next time we do one of those medical examinations thing, we had to find somebody with a hydrocele. I got a nice big one. I went from a normal size. To a lemon-sized overnight. It was explained to me that hydroceles occurred due to traumatic injury. Infection. Neither of those happened to me. Yeah, they just sometimes happen. Any insight why this occurred rapidly and any way to mitigate the chance of a recurrence? Ooh, I assume, they just drained it. Mitigate the recurrence, they will remove them surgically. I'm not sure I would do that. And then, as you see, if you recur, you just take the drain. That's all. I know that sounds gruesome.